Assalamu alaikum everyone. My name is Abdulellah, a second-year medical student, and today we'll be having a lecture about the bladder structure and micturition in the renal block. Before we start, this is my contact info, email and phone number. If you'd like to ask any questions, just feel free. So before we start, those are the major aspects of the lecture. We'll be discussing the bladder structure, the micturition process, and finally a couple of abnormalities that can help you guys with the overall image of the micturition process. So, Bismillah, we start with the first part, which is the bladder structure. So the urinary system is composed of a couple of organs. So we have two kidneys. We have two more structure, which is the ureters, also a bladder that stores the urine, and finally a urethra, which is a tunnel that moves the urine from the bladder to the outer wall. So just to emphasize the point that there's no modification or further modification on the urine after it leaves the kidney. Furthermore, I just emphasized the third point here because we're going to discuss it a couple of times in this lecture. So it states that as urine accumulates, the bladder expands without significant rise in internal pressure. You may just be shocked with this and okay, how there's no change in pressure, even though we're adding volume, which is a simple physics. But will be discussed. The main agent in this, let's say, mechanism is the detrosal muscle, which is a muscle, which is a smooth muscle that surrounds the bladder. Second, we have the urinary bladder that's composed of two main parts, which is the big part, which is the body, and then we have the neck. This image that's shown here, the upper part, which is the body, where urine is stored until we have micturition, and the second part, which is the neck, which is a tunnel that connects the bladder with the urethra, the external wall. Regarding the position of the bladder, it's slightly different between males and females as a physiological difference. So it lies mainly retroperitoneally on the pelvic floor posterior to the pubic symphysis. So this is common between males and females. Just to state that if you don't know what's retroperitoneally, you're going to take this next semester, inshallah. But briefly, you have the peritoneum, which is a space inside the abdomen. And behind it, we call those stuff are retroperitoneal. Just keep in mind, it's just retroperitoneal for now. Next semester or next block, inshallah, you're going to know more about this idea. Also, it's posterior to the pelvic floor, and then it lies, it's posterior to the pelvic, So it's posterior to the pubic symphysis, which is a cartilage structure that protects the bladder mainly and the genital organs overall. For males and females, there's a slight difference between them. For males, the bladder lies on the prostate gland. So unfortunately, this image does not show what I mean, but yes. So this image, this is a bladder for a male. You have here the bladder. Below it, there's a structure that looks like a nut. So it's smaller than the bladder. This is the prostate. It's like the bladder is sitting on the prostate. Whereas in the females, there's a slight difference where we have the bladder and nothing below it. It's just the urethra. And posterior to the bladder, we have the vagina and the uterus. So the bladder lies anteriorly to the vagina and uterus, and anterior to the bladder, we have the pubic symphysis. I don't know if I just messed you up, guys, but just to have the structure anatomically, we start with the pubic symphysis anteriorly. Behind that, we have the bladder. Behind the bladder, we have the uterus and the vagina. Lastly, to discuss in the structure, we have the trigon. Trigon is just from the name, it's a triangle upside down. It emphasizes 3 points, 3 openings in the bladder. The first 2 openings, the upper 2 ones, left to right. There are the openings of the ureter, each one from a kidney, and the bottom edge, which represents the opening between the bladder body and neck, where the urine is going to be released. For the layers of the bladder will be more emphasized in the histology lectures, but just to know that you have a transitional epithelial mucosa that helps in the expanding of the bladder, and then you have a thick muscular layer, and this thick muscular layer helps in the contraction of the bladder to empty the urine. And lastly, you have a fibrous-like structure that lies superiorly. For the bladder, just an overview, you have 2 steps. You have a filling phase and then emptying phase. What do we mean by filling phase? It's the phase that we add urine, or urine is being added into the bladder through the ureters coming from the kidney until it reaches to a specific level where we call it the threshold, where you're going to have those reflexes that alerts you that you need to go and micturate. Secondly, we have the emptying phase. The emptying phase is where we force the bladder, or there is a signals from the spinal cord where it sends a micturition reflex where the body starts to micturate. And you're going to feel that. We discussed this furthermore. For the micturition process, we have the filling phase. In the filling phase, guys, I need you just to focus on number 1 and 2, because those concepts and those 2 muscles or 3 muscles we can discuss going to come along the lecture furthermore. We have the detrusor muscle relaxes. So in the filling phase, this detrusor muscle is going to be relaxed. Whereas for the urethral sphincters, we have internal and external urethral sphincters. Both of them will be tightly closed. This is in the filling phase. In the emptying phase, we'll discuss something different where both of them gonna shift. The one that it's relaxed gonna constrict, whereas the one that is constrict gonna relax. Why? Interchangeable functions between those muscles to facilitate whether micturition or to block micturition. Now, just to familiarize you with the idea of internal urethral sphincter and external urethral sphincter. For internal urethral sphincter, it's involuntary muscle. It's involuntary controlled. It's a smooth muscle. So whenever you see a smooth muscle, you correlate it with involuntary movement or involuntary control. This muscle facilitates it helps in the prevention of emptying the bladder. So not all the time you need to have this relaxed so you can move in your life and proceed. So there's specific signals that result in this muscle to be relaxed. We'll be discussing that in further slides. Also, we have the external urethral sphincter. Exactly the same function. It inhibits it blocks the release of urine in specific times, and it also facilitates the micturition at specific times. So it's a voluntary muscle. So this suggests what? It's a skeletal muscle. And also regarding the locations of them, the internal urethral sphincter as shown on the picture to the right. Between the bladder and the bladder body and the bladder neck, there's a junction. At this junction, we have the internal urethral sphincter, which is a smooth muscle, and it contains an involuntary control. Whereas a bit below, so because there's a small distance between them, because this is a female bladder, you can see that the external urethral sphincter lies in the urogenital diagram. Well, what's the urogenital diagram? Don't bother yourself with at this block. You'll be having this in EndoRepro, ERP. But for now, just know that the external urethral sphincter is voluntary muscle. You can't control it. So it's a skeletal muscle. And also it lies in the urogenital diaphragm. For the micturition process, distension of bladder walls initiates spinal reflexes and results in. So what things that it may result in? So as the bladder wall in the image shown here to the right, you're gonna have that this is a bladder, and you're gonna have stretched receptors. So those stretched receptors, as the bladder is going to be filled with urine, they're gonna expand. So the transitional epithelium can expand. So the tissue or the organ overall, the bladder expands. With the expanding, we have stretched receptors. As we stretch them more, as they send more firing. When we say more firing, more signals are going to this through the nerve to the spinal cord. It goes especially and exactly to segments between S2 and S4. Those segments are responsible of the involuntary control of the micturition process. So, and it can come back as a motor neurons and affects 2 muscles that we mentioned earlier, which is the detrusor muscle and the internal sphincter muscle. For the internal sphincter muscle, it's going to be relaxed as we're going to initiate micturition, whereas for the detrusor muscle, we're going to have contraction of it. And this is the voiding reflex. Voluntary control, which is that we can inhibit micturition ourselves through which muscle you should recall. It's a skeletal muscle, which is a voluntary control. So probably it's the external urethral sphincter. Through this muscle, you can contract it. Everyone is able to do that to inhibit micturition. And this process overall is facilitated by the brain, especially a specific part of the brain, which is the pons. Don't bother yourself with knowing which part of the brain, and just know what's in the brain. And the micturition centers are located in the pons. And now for the law of Laplace. I know, guys, don't panic. It's not a physics class, but this law helps us understand the mechanism the bladder is working with. Why does, as I mentioned in the first slide, the first slide, we mentioned that as urine accumulates, the bladder expands without significant rise in internal pressure. So I guess most of you was like, how does the internal pressure is not increasing? This law, which is the law of Laplace, can emphasize this point. it states that whenever we have a sphere or a structure and we expand the walls and there's a fluid that pushes the walls as shown here, and the radius increases and the volume increases at the same time, the pressure again will stay constant. In a way that as much as we include volume to a specific structure, generally the pressure increases. So as volume increases, pressure increases. But in Laplace law, because the structure of a bladder is a rubbery structure where you have the transitional epithelium and it allows it to expand, as we increase the fluid, which is the urine, it pushes the walls. As you show, those lines shows us that there's a pushing toward the wall. So as we push the walls, we expand, we increase the area. So we increase the size of the area inside. The pressure it's not decreasing, it's just kept stable as long as we increase the volume and increase the radius. So as the organ fills, radius increases, but the pressure remains relatively constant. And this formula shows you that there's an inverse relation between pressure and radius. So as we increase radius, the pressure decreases. And as we increase pressure, radius decreases. You're gonna ask you, why is the pressure changing? And I just mentioned that pressure is constant. What's the game changer here is that the volume. Is that generally as we increase the radius of a specific sphere, the pressure decreases. But because we are adding volume, the pressure is kept the same. I know it's maybe you're kind of confused guys, but with the next slide, I guess it's gonna be more clear. The flatness of segment IB is a manifestation of the law of Laplace. Just keep in mind what is segment 1B. So this image, which is a graph that shows us a relation between the pressure inside the bladder and the volume also within the bladder. I know there's a lot of annotation here, but I added them in a way, inshallah, it may help you. Don't worry, the next slide is the same thing, just in word form, in a clear writing, but I just kept those annotations if anyone likes those illustrations. So this graph shows us the filling phase and the voiding contraction, which is the emptying phase. You can look that the filling phase is pretty long, and we made that long for like hours. It's broken down into segments, segment 1 and segment 2. Segment 1 is broken down furthermore to segment 1A and segment 1B. Segment 1A resembles the increase in pressure and the increase in volume also, as this is the first 50 milliliter that there's no increase in the size of the bladder, but the urine that has been added, which is the volume, fills the bladder, so the pressure increases. So towards this point 1A, there's an increase both in volume and pressure. Furthermore, we proceed into the second part of the first segment, which is 1B, where you can see pretty obvious that the pressure is constant, whereas the volume is increasing. And this is because of Laplace law. As we mentioned in the previous slide, segment 1B in this graph resembles and signifies the Laplace law. It's because as we add volume, this urine pushes the walls of the bladder, resulting in its expansion. So the pressure is kept the same, even though we're increasing volume. But it's going to reach to that point where the bladder can expand furthermore, and the pressure is going to jump rapidly, as shown in this, which shows the segment 2, the emptying phase, where we're going to have those reflexes of micturition are so painful or so strong. This means that even in the filling phase, there is a signaling of micturition. The sensory receptors, the stretch receptors that are on the bladder, going to send those signals. But compared to those signals, they were way more different. And in this phase, you can see that those signals are pretty low, and as the volume increases, they slightly increase. But the moment those reflexes increases rapidly is within segment 2, where it reaches around 400 milliliters, which is the average capacity of a normal human bladder. Of course, between children, male to female, there's a slight differences, but usually around 400 milliliters, you're gonna have this rapid jump in the pressure. I guess it's pretty clear. If anyone's having any doubts on those things, just contact me, because I think most people suffer with this point. Just I mentioned that in segment 1A, you have increase in volume and also increase in pressure. In segment 1B, you have increase in volume, but the pressure is constant. Why? You may have a question in the exam that you can have this graph, and the doctor is pointing toward the segment 1B, and he's asking why the segment is having constant pressure. Usually one of the options you're going to say because of the law of Laplace, because the fluid increasing pushes the walls of the bladder, so the pressure is kept the same. So you're going to have similar choices. And then in segment 2, which is the voiding contraction, the emptying phase, you're going to have a rapid increase in the pressure as there is no increase, or there's no widening, or just the bladder is not getting more big. So there's no room for more urine. So pressure jumps rapidly because volume is even though a volume is increasing slightly at this phase, as you can see, this because the bladder is not able to expand more, the pressure jumps rapidly. And this is a word form of whatever I discussed the previous slide. Now, those are two methods the doctor discussed previously, in the lecture. One is the uroflowmetry and the cytometrogram. For the uroflowmetry, is a test that measures the voiding volume, it measures the time, the average, and the maximum urine flow. Typically, this test is done that the patient is asked to urinate into a tunnel, and this tunnel is having sensors and devices that measures your voiding volume, your average time, your flow rate, and it's so important for patients with diseases. So this type of disease, the uroflowmetry, is used in patients to diagnose bladder nerve damage, sometimes for diabetic patients, and also for patients who have bladder neck stenosis. Bladder neck stenosis, they have narrowing of the bladder neck, so urine is just excreted in a low tone compared to normal patient. For those numbers, I advise you guys just to memorize them in case, because sometimes Dr. Abdullah had like to examine you on those range. So in case, just be familiar with them, and that, and as in men, as they age, the flow rate decreases, whereas in females, it should be kept constant regardless of the age. In case he asks about those questions, that are recall questions, so don't lose marks on them. Moving forward for the cytometrogram. So the cytometrogram is another device that's used in the clinic. It involves two catheters, which is a catheter that is double-headed, contains two loops, two lumens, one that's responsible for filling fluid within the bladder, and the other one is just to measure the pressure and volume within the bladder. Well, it's used to diagnose patients if they're having issues with the expansion of the bladder, the response of the bladder for micturition. So typically, as we mentioned, double lumen catheters. One, the blue one, it just add fluids, which is water, into the bladder. The second one, it sends the difference in volume, the difference in pressure. Now, I think this is the bulk of the lecture, which is how micturition is induced. It's involuntary control at first, and then the voluntary control. And how can we can stop at the involuntary control and micturition proceeds, and how we can induce and include the voluntary control to inhibit micturition. Don't worry, I'll be explaining on this slide. Next slide will contain everything, and it's written. So it all starts when the urinary bladder starts to be filled. The signaling starts with the first milliliter. A sensory fiber, which I mentioned, the stretch receptor, can send signals to the sacral segment. As we mentioned, that the sacral segment is responsible for the involuntary control segment, and it's S2, S3, and S4. So from S2 to S4 is responsible for the involuntary control. So those signals and fibers are going to go into the sacral segment, where they're going to send their sensory segments that we need to micturate. And as the bladder is going to be filled and the pressure is increasing, volume is increasing, the firing rate is increasing. So the urge to urinate increases. So we can have motor fibers that send signals to two specific muscles that we mentioned earlier today in this lecture, which is the tetrosal muscle and the internal urethral sphincter. We mentioned previously that the internal urethral sphincter, in normal cases, when there's a filling phase, it's going to be contracted, whereas the tetrosal muscle is going to be relaxed. In this case, it's going to be opposite. The muscle that was relaxed is going to contract, and the muscle that was contracted and constricted can relax to facilitate micturition. At this point, there's also sensory segments. Let's go back to the green line with number 1. It goes to the sacral segment. There's a shunt or another pathway that goes up toward the brain. It goes through the whole spinal cord until it reaches to the bones in the brain, where it sends us signals. So we sense that we are about to micturate. So at this point, you have the decision. So at this point, the involuntary control ends. And if you're going to do nothing, micturition is going to happen. If you're going to induce any signals voluntary from yourself, it's going to come back through this segment, the red one, goes all the way to the sacral segment again, and there's one of those that goes directly toward the external urethral sphincter. The external urethral sphincter, as we mentioned previously, is a voluntary muscle, skeletal muscle, that we can control to inhibit micturition. So this is generally how we can inhibit micturition and block micturition. Here, it's mentioned that there's the micturition centers in the bones, and those are responsible to receive signals from the sacral region in the back and send it to the bones and the brain. And it shows us that we need to micturate. So it varies, you know. So you have the decision. So usually people end with the involuntary control. If it's not appropriate, no time to do that, you're busy, you can have the voluntary control to inhibit micturition. Well, now there's a couple of abnormalities. The first one, some people are presenting to the clinic with automatic bladder. So the name suggests that there is a automatic micturition process occurring, and you can't inhibit that. And this is caused by damage for the sacral segment. Any damage, just look at the image. This is the sacral segment, we can say. Let's say that this is below this line is S1, S2, S3, S4. This is the sacral segment. Any damage to the spinal cord above this region, so it's L5 and above toward the brain, towards C1, so from C1 to L1, and those are the segments of the spine above the sacral region. And this can specify any damage to this region can result in loss of the voluntary control. So those patients can present to the clinic and they can't control their micturition. They just urinate suddenly and they can't stop it. So probably, I guess the doctor would have a question in the exam, like a patient, let's say a 45-year-old patient, male, who had a car accident 1 week ago. He had a spinal damage, and since that, he's not able to control his micturition. So you're going to suggest automatic bladder. Now, more abnormalities. We have the stress abnormality, and this, in Arabic, we call it al-salas. And those patients, they have increase in the pressure of the thorax or the abdomen, where it's sometimes secondary to coughing, sneezing, laughing, and those patients have impaired sphincters. So any increased pressure in the abdomen or the thorax can result in releasing of urine, and it's not urinating, but you can see that there's droplets in the patient's urine. In severe cases, yes, they can urinate, but usually those patients can have those like 1 to 2 seconds urinating, and then they can't control. Whereas in the acute retention of urine, it usually occurs in elderly, and this caused by enlargement of the prostate gland. So we can say that this mainly occurs in males as it affects the prostate glands. So as the prostate glands enlarge, it narrows the prostatic urethra, and narrowing the prostatic urethra can result that the patient is having difficulty in urination because the opening that the urine should go through is narrow. So there's a decrease in the tone. Sometimes they need to facilitate that by increasing the pressure in their abdomen and just pushing themselves to urinate more. Also, we have the chronic prostatic obstruction. And this, it's like pretty similar to the acute retention of urine, but here we have chronic, so it's over a long period of time. So we can say that it's a gradual narrowing of the prostatic urethra that raises the urethral resistance, which the bladder must overcome. So patients should just themselves push and increase their pressure so that the bladder pressure becomes more than the constriction area pressure, so urine can pass and they can urinate. So generally, both of them are similar, but the difference that this one is because specifically the prostate gland, and it's in a short period of time, this one in a chronic state where it's a gradual narrowing. So the patient throughout a period of time, for like 4 months, 5 months, can see that throughout those 5 months, he can see that his urine flow rate is decreasing and he needs to put more force to urinate. Last syndrome in this slide is the overreactive bladder syndrome. Probably the name suggests that those patients presents with a sudden urge to urinate. So at sudden, there is an overreactivity, whether of the reflexes, those spinal segments that send those reflexes are just overactive. Sometimes the trigon region in the bladder, it's hyperactive, as we mentioned. Just to recall, this is the trigon region where sometimes it's hyperactive, so it sends, if there's like 50 milliliters, 100 milliliters, which is not a full, we mentioned that it's usually 400 milliliters to have a full bladder. Sometimes those patients like have 50, 60 milliliters and they need to urinate and it's urgent and they can't control it normally as other people. Or typically seen in elderly people as they grow, they have muscle weaknesses, some diseases, so they affect those muscles of the bladder and the region overall. Last abnormality with us for today, which is the micturition syncope. Well, to be familiar with the concept of syncope, is that the patient present with fainting, they lost consciousness, and there's several causes of it. One of those causes is the micturition, and it's a medical term for fainting, syncope, while urinating or after urinating. And you would ask yourself, how does that occur? Someone is urinating. We mentioned in the previous slide that some patients who have constriction of the prostatic urethra or any segment of the urethra, they find difficulty urinating. And to overcome this difficulty, they need to apply force. And with applying those force and increasing pressure, the blood pressure increases. So as mentioned here, when one strains to increase the flow of urine, as people with, for example, having chronic, let's have an example of patient who's having chronic prostatic obstruction. So he's having a decrease in the urethral flow, in the urine flow. So he needs to apply more force to increase pressure to overcome that. So this patient, who's for let's say 70 years old, is applying more force to increase the flow of urine. So this gonna activate an important nerve in the body, which is the vagus nerve. Activating and stimulating this nerve can result in bradycardia, which is affecting decrease in the blood in the heart rate, which is below 60, if I'm not mistaken. So the normal range from 60 to 100, they can have a blood of a heart rate, of less than 65. With that, the patient gonna be bradycardic, affecting the SA node, AV node, and this is done by affecting the baroreceptor reflex. As I guess you talked that, you talked that in the CVP block, that there's a correlation between the vagus nerve and the baroreceptor reflex. So activating the vagus nerve can also affect the baroreceptors that are present in your in this region. You're gonna have the baroreceptors. So the baroreceptor reflex generally, it's specified that as blood pressure or as the firing rate increases, this signifies that there is an increase in blood pressure, even though if there's no, you can just trigger it by your hands. As you move your hand at the neck region, you are triggering your baroreceptors, so you're inducing baroreceptor reflex. Inducing this baroreceptor reflex can result in decreasing in the blood pressure. One of those ways by inducing bradycardia of the heart. Also, this can result in blood vessels in the legs to dilate. And the dilation of those blood vessels can result in drop of blood pressure, venous pooling in those patients, and there's decreased on the cardiac output. So generally the pressure in the body decreases, the blood pressure decreases. So this is going to affect the patient. So the body, to save the patient is going to faint. And we mentioned that as micturition syncope. This also can be worsened and can be fatal in some patients who are dehydrated or having nervousness or urgency. So all of those factors can build up on the decreased pressure induced by the activation of the baroreceptor reflex as the vagus nerve is triggered by a patient who's trying to overcome the pressure of the constricted area to increase the flow of urine. So this is an important indication that this patient is having a life-threatening case if he's having this repetitively. Thank you guys for attending this PAL session. Don't forget just to scan the QR code for the review. And also, this is a past practice questions collected by Haneen. You can go over them, solve them, but just make sure that you go over the slides because some of the questions is not here. go over the practice questions, go over the lecture. And if you have any questions, just don't hesitate, just text me or just email me, and I'll be more than happy to help you guys. And thank you for attending this session. Assalamu alaikum.